Bismillahirrahmanirrahim. Here you can see the normal condition when the increased abdominal pressure act on the bladder as well as the urethra, which cause the closure of the urethra. But if there is no support of the pelvic floor, so what will happen? It's remain open. That lead to the urine leakage. Okay. So how we manage the stress urinary incontinence? Initially, we start with the prophylactic and then conservative treatment, and the final approach is the surgical approach. Okay, in the prophylactic, I mean, you treat the predisposing factor and good obs care and the postnatal pelvic exercises which prevent from the weakness of the pelvic floor. Okay, and the hormonal replacement therapy in the postmenopausal woman, and proper surgical technique to avoid the securing at the bladder neck. There are different the Kegel exercises for the stress urinary incontinence, because these exercises which strengthen the pelvic floor, so which help the stress urinary incontinence. Okay, so and the conservative treatment, you change the lifestyle, I mean weight loss, stop the caffeine and smoking, fluid management, and the medical estrogen and these anti-adrenergic, anticholinergic. In the physiotherapy, of course, the causal exercise, the pelvic floor exercises. In the mechanical, you may give the pessary or the weighted cones, which actually prevent the prolapse. Okay, and other are the artificial sphincter placement and the parajurethral bulkage and like collagen and fat. We will see in these condition in the next pictures. And the surgical approach, first of all, you have to do the Kelly suture, which for the vaginal urethroplasty. Okay, so it actually they applicate the paraurethral fascia on the either side of neck by 2 to 3 sutures. So these are two U-shaped suture and the mattress which support the pelvic floor. Okay, so here you do the different suture at the neck of the bladder. Okay, so which somehow support the bladder neck. Okay. The next is the William operation, or for the abdominal cystopexy, where you suture the front of urinary bladder with the pubic bone. So here is a pubic symphysis. Okay, so here is a bladder neck. So we do the suture in between the bladder and the pubic symphysis, so which prevent from the prolapse of the urethra down. Okay. So in this picture you can see, so this is a suture of the William operations. Okay, and the next is the urethral sling procedure, where you put a sling to support the urethral neck. Here is you can see sling which support the neck. Okay, so there are the minimal invasive sling procedure like TVT or TOT. So TVT means tension free vaginal tap, and the transobturator tap, and the TVT secure sling. So same thing, but in the tension free vaginal tap, it's associated with the abdomen. The tape is attached with the abdomen, while in the transobturator it's attached with the obturator foramen level. Okay. So there are the different theory to how to treat the condition. If there is uretrovesical angle change and there is hypermobility, so you start the Kelly application or the retropubic suspension. So we will see this, and there is bulk agent injection, and there is hammock theory. So we will see the mid urethral sling in the next pictures. Okay. So this is you can see the TVT vaginal, where you can see this is the tape. Okay, so here is a tape which is attached with the abdominal wall. Okay, and here you can see so this is the same pictures. Okay, which is supporting the same picture is also expressing here is the bladder. Okay, so this is the sling which is coming out here like this. Okay. So what is the TOT mean, where the instead of abdomen we attach with the obturator foramen. Okay, so this is not attached with the abdominal wall. So here is the obturator foramen. So at this level. Okay, so this is the TOT and the pelvic suspension. It actually make a suspension for the Culpose suspension, where you make a suspension by the vaginal wall to Cooper's ligament. Let's look at this picture. So where you can see here is a suspension. One side is here, other side is on one side. Let's see is the vaginal wall. On the other side, there is the Cooper's ligament, and there is the hammock, the suspension or swing, where the urethra sit. Okay, so same thing you can see here. So here is the suspension, and this is a bladder which is resting over the suspension. Okay, so same thing is happening here. So this is the Cooper's ligament. Okay, so here is the bladder. Okay, so this is modified. So same thing is happening here. So there is also the urethra, and this is the sling. Okay. Other approach is the intraurethral injection, where you give the polyacryl amide hydrogel. It's actually a bulking agent, so it's make a bulk over here. So okay, and like here, so this prevent from the leakage of the urine. Okay, so how we do? We give the endoscope with the needle. So and put this bulking agent here. Okay, so here on this side you can see this is the vagina, and here is the bladder. Okay, so you give the vaginal pessaries like here, so which prevent from the urine leakage, because it's somehow helping the bladder neck. Okay, so it's helping the bladder neck. So you can see these are different pessaries, and here you can see this pessary is present in the vagina. Okay, which also helping the bladder neck. Okay, same thing is happening here, so it prevent from the urine leakage. Okay, this is summary of the different the procedure. Okay, so TVT, where you give the tape through the vagina and attach with the abdomen. Okay, and the TOT, where you enter from the vagina and attach with the tape with the trans obturator. Okay, and here is the culpose suspension. Okay, where you attach the vaginal wall to the Cooper's ligament. Okay, so Cooper's ligament and the vaginal wall, and in the intraurethral injection. Okay, so you put the bulking agent here. This is the vaginal pessary. So we have discussed this management of the stress urinary incontinence. Thank you very much. Allah Hafiz.